So I'm Jeff Weber. I'm a medical oncologist. I'm the head of the research center in melanoma. And I'm just going to take a little bit of your time this morning to tell you about some recent therapeutic advances, some of which are very exciting. 10 years ago, being a medical oncologist in melanoma was a tough job, but 10 years from now, I think it's going to be a lot more fun job because we'll have lots of drugs that actually work, and I'll tell you a little bit about them. But to do that, I have to give you a little instruction in the immune system, because a lot of the drugs that we do use and will use relate to the immune system. So first, the message, and this refers to the way things used to be in melanoma. It's a bad disease. Once melanoma spreads and metastasizes, it's bad news. But there's a very famous guy who is the chief physician at the Dana-Farber, DFCI is the Dana-Farber Cancer Institute in Boston. He's now retired, but he always said that melanoma is the tumor that gives cancer a bad name. And I saw him recently. He's probably in his mid-70s. Very charming, very distinguished guy. And I said, George, do you still feel the same way? And he said, well, you know, things are changing. And he's right. And one of the reasons is now we understand how to harness the immune system. So what is the immune system? Well, we all know that we all have an immune system, and it evolved over many, many thousands of years of human existence basically to protect us against infection. And it has all kinds of different ways of protecting us, and it has two branches. One's called innate, and the other is called adaptive. And you have immune cells, and you have immune chemicals, so you have different ways of being protected. And the different parts are, as I told you, the innate part. And the innate part is kind of like the pre-existing part of the immune system. It's like a booby trap. It's always there. And you kind of booby trap things so that if the infectious agents, the bacteria, the viruses, invade your body, you can sort of booby trap them. You can get rid of them. And the innate immune cells have names. They're called neutrophils and macrophages. And it's not very selective, and it's not very educated. It sort of kills them first and then asks questions later. But it works pretty well. It's pre-primed to protect you, and we need it. The other side of the coin is what we call the adaptive immune system. The word adaptive means can change. And the adaptive immune system has different types of cells. They're called B cells and T cells. And they're educated in that they can actually learn. They can do different things. And that means they have memory. And it looks like we're missing the bottom line here, but the immune cells, the T cells and B cells, have a memory. That means they can remember prior exposure to a bacteria, a virus, whatever it is, dirt. And they can actually respond by, once they've remembered the stimulus, they can divide and divide and divide. You can get a very vigorous immune response. So let's say you're a young person, you get exposed to flu, you'll have an okay immune response. 2 years later, if you get exposed to flu again, your cells have been educated. They remember the flu, and they really, really vigorously protect you, and you won't get the flu. But the immune system, as I always tell people, is like the Department of Defense. We have a very elaborate immune system. A lot of your energy goes into your immune system. And it's kind of like the Department of Defense because our immune system is elaborate, but it's mostly going to protect you against bacteria. The US military is also very elaborate. Costs a lot of money, and it gets rid of, you know, bad guys, dictators, threatening types. The immune system has different branches, and so does the Department of Defense. The Department of Defense has the Army, the Air Force, the Navy, the Marines. So there are a lot of similarities. And when you get an immune attack, that is, if you all get an infection with flu or a tumor or a bacterial infection, your immune system attacks simultaneously with the innate and the adaptive groups. It has the B cells and the T cells. And the military works the same way. It's not just the infantry, it's the artillery, it's the Air Force, it's the Navy. They all work together. It's called an all-arms attack, just like your immune system. And the tumor cells are pretty nasty and sleazy. They evade and avoid the immune system, and that's one of the biggest problems. And similarly, when we attack bad guys, the enemy uses camouflage, they evade, they have stealth technology, they jam our radars. So the bad guys also have lots of ways of being sleazy and sort of escaping our Department of Defense. So, why doesn't immunity work so well against cancer? It certainly works against infection. With the help of antibiotics and antivirals, most of us are alive and well, even though there are lots of bad guys out there, all kinds of infectious agents. Well, keep in mind that cancer cells are derived from normal cells. They look very, very much like your normal cells in many ways. And they differ in the expression of genes that are normal. There aren't that many genes that are mutated or different in a cancer cell, actually relatively few. And the cancer cells are very slippery. They evolve to lose the expression of those things that your immune system can recognize. So that's a key thing. And they produce all kinds of nasty substances that are suppressive. We call them suppressive cytokines. So the cancer actually evolves in your body through your lifetime. In fact, through the lifetime of the cancer, it might only be a couple of years. It evolves, and it can evolve to produce things that suppress the immune system. And also, patients who are sick with cancer have just not, the immune system doesn't work very well. Because once you become ill, your level of energy is low, and your ability to maintain an effective immune system is not so good. So, how can we exploit it? In fact, how do we exploit it? Well, keep in mind you got some serious problems. Your immune system did not evolve to eliminate cancer. Back in prehistoric times, most people's greatest risk to life and limb was infection. It wasn't cancer. You know, go back 10,000 years, the average human only lived about 30, 40 years, and everybody died of, you know, a saber-toothed tiger bite or God knows what, or some horrible infection. They didn't have antibiotics. They didn't have any modern medicine. Now we all live, I guess the average lifespan is in our late 70s, early 80s for men and women because we have antibiotics, we have protection, we have modern medicine. But, so the immune system evolved mostly to get rid of infection. So we try to exploit it to get rid of cancer. And here's how we do it. If you look at the immune system in cancer, here's an immune cell. And here's your cancer cell, and it has to link up with these different substances to actually recognize the tumor cell. And so it has to show the antigen is a substance that's on the surface of the tumor cell that could be recognized. No antigen, no recognition. So you have to have an antigen. And you have to have this thing. See the little red thing here? It's called the major histocompatibility complex. So it shows the immune system stuff, and if you can't show anything to the immune system, you've got no recognition. But let's say you have it. It also has these other substances, and see these numbers and letters, CE28 and B7. You have to link all these things together to get the immune cell to recognize the tumor. It's kind of complicated. And what happens is your immune system normally allows this to happen. But the problem is, inside this yellow immune cell, there's all this stuff. And that stuff is the brake. Because if you have an accelerator, you have to have a brake. That's the way it goes. So this CTLA-4, this thing up here, gets produced inside the immune cell and kind of puts the kibosh on the immune response. So if you could block the brake or cut the brake, you might actually promote the immune response. And that's what we do in the clinic. We have this little guy up here. That's an antibody. See the little red thing? Looks like a propeller. That's an antibody, and it blocks the brake. So what happens is, if you have this CTLA-4, this is going to put a brake on the immune system. If you have the antibody, it gets rid of the brake and allows the immune system to work better. And what happens is, and it just shows you and it's a bit of a silly photo, but you start off the immune system kind of like running your car. You turn the key in the ignition, but that's not all you need to get the car to work. You have to press on the accelerator, right? Just starting the car doesn't make it move. You release the parking brake and you press on the accelerator. So the first step is the T cell recognizes this foreign substance on the tumor cell. Then you have to have these guys link up together. That's the accelerator. Well, the problem is if you get this thing called CTLA-4, and now there's another one, it's called PD-1, that's like hitting the brake. And that's okay. If you all had a virus infection, you wouldn't want immunity to go on and on and on and on. You'd die of autoimmunity. You have to stop the immune response sometimes, so you need an accelerator and a brake, right? Your car has both. You don't just accelerate. At some point, you have to stop the car, so you need a brake. The problem is, in cancer, it's like you're in a car where the parking brake is permanently engaged, and you can't, your car will move. It just doesn't move well. Anybody ever try to start their car moving with the parking brake engaged? I certainly have, especially if it's a rental car that's not familiar. And you press on the accelerator, and the car moves, and it's real sluggish. And you say, what the heck is wrong with this car? And then you look down and say, oh my God, the parking brake's on. You take it off, and now the car moves fine. Well, your immune system in cancer is like my car moving with the parking brake on. It moves, it just doesn't move very well. So if you could take the brakes off, and it turns out that with our drugs, we kind of cut the brake cable, it moves really well. Stopping is is a little difficult, but still it moves very well. And then my colleague who made this slide threw in the steering wheel. Obviously, you turn the key, get rid of the brake, press the accelerator. You have to, obviously, you have to steer it in some direction. So we're not going to talk today about vaccines, but in the future, not only will you promote the immune system by cutting the brake, you'll also direct it by vaccinating, and we do that in the clinic too. So I just show you one slide, and it shows if you use this antibody, and it has a ridiculous name, it's called ipilimumab. And I've tested this drug extensively, and I point out this orange stuff over here. These are numbers that describe survival. And if you look at the survival at 1 year and 2 years in patients who have melanoma that has spread widely, meaning it's metastatic, it ain't very good. A third of the patients only are alive at 1 year, and then 80-some-odd% have died by 2 years. So the survival at 2 years is 17%. With this drug that we use, that is an antibody that cuts the brake cable on the immune system, these are different trials, different groups of patients. If you take a look and compare these numbers to this number, I think you'll agree these numbers are very different. With this ipilimumab drug, you get at least a third of the patients on average alive at 2 years. If you had the relatively ineffective chemotherapy drugs that we've used in the last 10 years, that's what you get. That's lousy. This is not bad. And if you look at 1 year, same thing, so this is 2 years. If you look at 1 year, in general, more than half the patients are alive, but it was only about a third if you just use chemotherapy. So the bottom line is, we're probably making a little progress, and this isn't tiny numbers of patients. This shows the number of patients. So here, 200, 150, 115, add them up and you got more than 400 patients. That's a respectable number. And this is a drug, again, it's an antibody that inhibits the brake on the immune system, and I think it does a pretty decent job. Now, it turns out that unlike chemotherapy, when we use this antibody, which again is an inhibitor of the brake on the immune system, the tumors often shrank, but they didn't shrink very quickly. It was really slow. And sometimes the tumors would even grow, which normally signals the failure of the treatment, but then they'd go away. Very bizarre. And in some cases, new tumors would pop up. Then the old and the new tumors together would just subsequently disappear, which again is unheard of with any kind of chemotherapy. And that's unique to these antibodies that inhibit this thing called CTLA-4. So I'll just show you a couple of scans. So here's a patient who starts out, and you see all these little lumps here? This is a patient who had a bunch of lumps in the belly wall. So this is a CAT scan that shows the wall of his belly. That's his kidney, and the little circles here are not tumors, they are cysts in his kidney. 3 weeks into the treatment just started. He only had 1 or 2 doses. Uh-oh. I mean, I think you'll all agree there's a lot more stuff up here than there was when he started. So it looks like the tumor's growing, and the patient could feel it. And the patient could feel the tumors growing in the skin of his abdominal wall. He came back and said, "Forget it, buddy. I don't want to continue this treatment." So the patient was encouraged to continue because 4 months later, they're almost all gone. And this patient went on to have essentially no further tumor. He had a complete remission. But it took 4 months to achieve it. And 3 weeks into the treatment, it was actually growing. So it took some serious convincing to convince this patient to continue the treatment. Here's another set of scans, and I think you don't need to be an oncologist to figure out if that's your liver. So again, it's a CAT scan. It cuts through the center of the body, and it shows a cross-section of the liver. The black stuff, by the way, is the lungs, and there's your spine. So you start out with the liver looking like this. 12 weeks into the treatment, the patients had 4 treatments with this antibody, and oops, I think you'd all agree that's bad. I mean, there's tumors all over the place. All those little black circles are new tumors. This is not good, and the patient felt lousy. The liver functions in the labs were abnormal, so this is not my patient, but it was a patient of a friend of mine at Memorial in New York. So he took the patient off the treatment and said, "This is bad. We're going to find a new treatment." And he had to wait a long time to put him on a new trial for various and sundry reasons. And you go then to week 20, so it's 8 weeks later, and he was about to put the patient on a new trial, hoping he could help him, and he got him a new scan. Tumors are going away. Now, he hadn't done anything in the intervening 8 weeks. He was just waiting. And he noticed that the patient felt better. It's kind of interesting. And then he waited again and got another scan. And now you're out to week 36, so it's another 16 weeks. And now the tumors are gone. Can't see any more tumors. Now, he hadn't done anything further. There was no further treatment. And actually, this is a true case of a patient who is now 3 years out from his treatment. Actually, it's a high school history teacher in Long Island, New York. And the guy's free of disease. He's fine. He's back at work. He teaches history at some high school somewhere in a suburb. So the guy's fine. But this is weird. I mean, you don't see this with chemotherapy. You don't see this with any treatment for cancer. So there's something unique and bizarre about these drugs. They work, but they work in a very strange way. And they have unique side effects. So the flip side of the coin of working in a very weird way, that is having growth and then shrinkage, is it causes weird side effects. And it was found when you use this antibody that cuts the brake on the immune system, guess what the major side effect was? Overstimulation of the immune system, the normal immune system. So it caused inflammation of different organs in different parts of the body. Some of these side effects were unique, meaning they had never been seen in the state of nature before. And you got inflammation of the colon, rashes, inflammation of the liver, swelling of the lymph nodes, crazy stuff. And in some cases, the side effects were associated with benefit. So I'll just show you a couple of shots. In the state of nature, you essentially never see swelling and inflammation of the pituitary. It almost never happens. Pituitary is a little gland at the base of the brain. It's very small. That thing is the size of your pinky nail, or even smaller. And it's like the master gland. It controls your thyroid, your adrenals, and all kinds of other glands. And it usually functions unobtrusively, does its thing, and it just doesn't bring itself to attention. But look what happened here. This thing swelled to 3 times the size and looked very abnormal, and this patient had a horrendous headache after getting this CTLA-4 antibody. It's actually interesting. The only change in the patient's body was this. This compared to this means it goes from your pinky nail to maybe your thumbnail. It's not a very big change, but the headache was horrendous, and the patient had to be admitted to the hospital. Well, it turned out the patient developed inflammation of the pituitary and fatigue, stopped making thyroid hormones, stopped making adrenal hormones, but as soon as they were given pills to replace them, they were fine. And this phenomenon is associated with doing well, because if you look at this curve, forget about the letters, just look at the curves. There's a yellow curve and a blue curve. The yellow curve is the curve of survival over, so here's time, and that's percentage alive. And if I were given a choice of being on the yellow curve or the blue curve, I'd obviously choose the yellow curve. The yellow curve is the group of patients who had these weird side effects. They have a name. They're called IRAEs. It's a stupid name. It means immune-related adverse event. It means an immune side effect. Those guys did a lot better than the guys in blue. So it says for the first time, we now have a drug that probably works, that cuts the brake on the immune system, that has weird mechanism of action because the tumors often grow before they shrink, and it causes unique side effects that are associated with benefit. Now, that doesn't mean you'll have no benefit if you get no side effects. It just means if you get the side effects, you're more likely to benefit from the drug. So again, if I had a choice of which curve to be on, I'll take the yellow curve any day. And over time, the curves open up. So this gets bigger. You see up here, in the first 6 months, there's no difference. Over time, it shows that the folks who got the side effects are clearly going to do better than those who don't. And that's very interesting. And that's not the only drug that cuts the brake on the immune system. I've done work in the laboratory, and we're about to start using another drug. It's another antibody, and it functions like that CTLA-4. It cuts the brake on the immune system. But this time it's a little different. This one's more like a sniper rifle. This CTLA-4 antibody was like a shotgun. It cuts the brake on the immune system everywhere. This PD-1 antibody, this is another immune brake. So PD-1 is increased on your immune cells in cancer, and it makes them not work very well because it breaks their function. It's not an accelerator, it's a brake. And this PD-1 now has an antibody that blocks it. It's just entered trials, and it looks very promising. It also can cause shrinkage of tumor with fewer side effects, and also has this weird, sometimes you'll see growth and then shrinkage. And like I said, it has fewer side effects than the CTLA-4 antibody, and it's very focused. It focuses its effect on the immune cells that impact on cancer. Fewer side effects means it focuses less of its effect on all of your general immune cells. And I just show you, this is the earliest trial that was just recently done. It's about to be published. It just shows a tumor up in the shoulder of a patient clearly getting smaller with the use of the antibody. No side effects to the patient,
But the investigators, and these are folks from Hopkins, found this is the tumor when you start. They stained for immune cells that are turned on, and you went from no immune cells to immune cells in the tumor, and then after 4 weeks, lots of immune cells. So what it did was it released the brakes and allowed the immune cells to get in the tumor and destroy it. And interestingly, it didn't have many effects on the normal organs, so it appears to have its effect confined to the tumor. So this is very promising. Finally, there are only 3 places in the United States that do a very unique kind of immunologic treatment. It's called adoptive cell therapy. So forget about the words here. Look over here at the picture. And what it shows is if you remove a tumor, so here the patient's got a tumor that's been surgically removed, and you isolate the immune cells, the T cells, which are in the tumor, and we know they're in the tumor because you can chop up a tumor and see the T cells. They're just not doing any good. So the immune system has been suppressed within the tumor. As I told you, the tumor is very slippery and evasive. It secretes things that suppress immunity. So what if you could chop out the tumor, and if it's, I don't know, at least yay big, you remove it, you chop it up, you make it into single cells, literally you chop it up, and you can grow the cells outside the body. You get rid of the tumor cells, which are eaten up by these now activated immune cells, and you expand the cells. And you can really expand them. You can start out with 1 million cells and grow them to 1 billion. In fact, we can grow them to 50 billion. And then you put them in an IV bag and you infuse them back into the patient. And just before you give them to the patient, you give the patient some chemotherapy which depletes their own T cells. Now, their own T cells don't work very well. So getting rid of them, no negative consequences from the point of view of the oncologist, but you give them the T cells that are now all revved up that you grew outside the body, and it can induce, in some cases, dramatic responses. And I show this yucky, ugly picture. It shows a single patient, and that, I believe, is the neck. So he's got this gigantic lymph node in his neck. It's ulcerating. And this is the underarm. It's the axilla on the right side of the patient. That's his chest wall. And it has this horrible, disgusting tumor that's growing out of his chest wall. He got these cells given to him in the veins. He got 50 billion cells, 5 times 10 to the 10th cells. And he had been given 2 chemo drugs, Cytoxan and fludarabine, to get rid of his own T cells. Then he got these given in the veins over about an hour. And then he got something to nourish them and keep them going, this interleukin-2. And he went from here to here and here to here. This was a guy who 3 months later had a complete remission. And this was horrible, ugly tumor. And this is very impressive. And when this treatment has been done, the response rate's about 50%. And this is only done in 3 places in the US, and this is one of them. And this is from my old boss back at the NIH who pioneered this. It shows how well the patients do in terms of their survival. And these are all patients who've failed multiple therapies, and their survival on average should be about 6 months. So if you look, 0.5 is the average. So that's the point at which half are alive and half are not. And if you extrapolate out here, it's actually like 18 months. That's not bad. If you give them more radiation and chemotherapy to really get rid of their immune cells, then give them back these cells that grow outside the body, works even better. So the yellow and the black curves are better than the blue curves. So we're trying to figure out how optimally to do this, how to rapidly grow the cells, because they take 4 weeks to grow outside the body. That's a long time. So we're trying to figure out how to do this. We work with MD Anderson, we work with the NIH. So this very promising, but difficult, expensive, and it requires that you have a tumor that you can easily remove and then chop up and make the immune cells. Not an easy thing to do. But in the future, this is hot stuff. I think this is going to be very impressive. So finally, Vern told you that I'm also going to describe how you can use other means other than the immune system to make tumors go away. And there are ways of targeting the tumor. I showed you this stuff with the releasing the brake on the immune system. The reason why it causes all the side effects is it also affects the normal part of the body. What if you could somehow directly target only the tumor? Well, not so easy. Everyone wants to do that. But it turns out that some tumors, especially melanomas, have mutations in certain genes. And it turns out if you analyze the genome, the genes of a melanoma, you have hundreds and hundreds of mutations. But some of them are in genes that cause the tumor to be addicted to the gene mutated product. So the genes encode proteins generally. So if this mutated gene encoded a protein that the melanoma became addicted to, and you could block this specific protein, just that protein, they would all die, right? Tumor would go away. And because your normal cells don't have mutations, they have normal DNA, shouldn't affect your normal cells. So it turns out that 50% of melanomas have a mutation, and the gene has a name. It's called BRAF. Don't ask me why it's called that, long story. But the BRAF gene is mutated very commonly in melanomas. It's always melanomas from the skin, which is almost all melanomas. Never happens if you have a melanoma from the eye. Why, we don't know. And it has a lot of amino acids. It has like 700 amino acids. But it turns out the number 600 amino acid is always mutated. Instead of being one amino acid, there's a mutation in the gene, and it makes it into another amino acid. And this makes the melanomas addicted to the presence of this protein, this BRAF. So if you could inhibit it, melanoma is going to croak, go away. So if you look at the testing of this in the test tube, so forget about all this junk over here. Just look at this. This just shows what happens in a mouse if you grow a human tumor in a mouse, which is possible, if the tumor has a normal gene for this BRAF. Nothing happens. The blue and the black show that it grows equally well in the presence of an inhibitor of the BRAF. The inhibitor has a name. It's a really dumb name. It's called PLX4032. All of our drugs have numbers and names, and it's really a drag to remember them. But if the melanoma has the mutation, this is what happens if you treat it with the drug. No drug, it keeps growing. You know, it's going to kill the mouse. But if you treat it with the drug, it goes away. And the red line goes down to 0. That means the melanoma has disappeared. So that's a good thing. So it says in this animal model, you can make the melanoma go away. And it turns out in patients, it works too. So again, here is a PET scan. And many of you have had PET scans. It's a scan done to detect the presence or absence of tumor. And at the time, this particular patient, who actually was from Vanderbilt, so it's a patient of a colleague of mine, started out, look at all the black dots. I mean, this patient had tumors all over the place, had failed multiple therapies, was very sick. So each dark black dot is a melanoma. And most of them you could feel on the skin, some of them you couldn't, they were inside the body. Just a couple of weeks after starting, so this is 2 weeks after starting this drug that I showed you made the melanoma go away in the mouse. It's a pill, and you take the pill twice a day. Almost all the black dots are gone. Some of them are still here. That's the bladder, which always looks dark because that's where this material that you do the PET scan with collects. It also collects in the kidneys, so you can see the kidneys, but most of the tumors are gone. That one is still there. That's probably in the lungs. So it looks pretty darn good. So very impressive, rapid decrease in the PET scan. And this shows you what happened to the tumors. And this is something called a waterfall plot. If you see 0, that's the baseline. If the tumors are below the baseline, they shrank. If they're above the baseline, they grew. It's pretty obvious. Most of the tumors are below the baseline. That means that almost all of them shrank. And if they passed the dotted line, which more than half of them did, that's a so-called partial response. So this was the first test of this drug. And this, it's not even been published yet. It's been presented publicly. But this drug, which is an oral agent, which some of you in this room may have had, shrinks the vast majority of melanomas. And it turns out the response rate is probably 70%, which is unbelievable. The duration of shrinkage is good. It's probably 6 or 7 months. And to be honest, not that many people are cured, but at least a huge proportion of patients have the tumors shrink. And what you do is you give other drugs to try to overcome the resistance to the shrinkage. And if you can use this drug, this PLX4032, and add other stuff to it, you may be able to cure a lot of patients. And this is hot stuff. This is hot off the press. This has not been published. These are things that will be presented in June at our big cancer meetings, as will some of that other stuff I showed you. So this is very promising. So what can we conclude? Well, the immune system is incredibly complex. The cancer tries to suppress it very well. But that antibody I showed you, anti-CTLA-4, otherwise known as ipilimumab, you can use that to manipulate the immune system and boost its effects. You can take the brake off the immune system. There's that new drug called anti-PD-1, does pretty much the same thing, probably with fewer side effects. And you can manipulate the immune system for the first time ever. It's never been done, and treat cancer. There are some new antibodies coming along that even look more promising, that are less toxic, that are more directed to cancer. You can grow the immune cells outside the body. That's called passive immunity, because you just grow the cells and you transfer them passively. And they can cause tumor shrinkage in lots of cases, but it's very complex, very expensive, and not all patients happen to have a tumor sitting on the skin that you can easily remove and chop up and grow the immune cells from. But if you could figure out how to extract the immune cells from the blood, which is not easy, and expand them and then inject them in the patient, you'll be way ahead of the game. And finally, I showed you the first truly targeted drug in melanoma. It's called PLX4032. You're going to hear more about it. That drug has been in a phase 2 trial, which we participated in. That means about 120 patients were treated all the same way, all got the drug, and the purpose of the trial was to find out how effective the drug was. We don't know the final answer, but all that I can say is if the response rate is as good as the preliminary stuff that I showed you with that waterfall plot, if it's even got a 50% response rate, that's the kind of drug that gets approved by the FDA. And that drug is a pill, and that drug will enter community practice in a year or two, and I think that'll be a tremendous advance.